Hey team, sorry I'm not there today with you guys to do your CBI. I am running 16 miles in the Ragnar Relay with our school's team, Gang Green, and I'll be running probably right now as you guys are having CBI, and in 12 hours from now, and then from 12 hours after that on Sunday. So let's get started. Alright, so the drug classes for antiretroviral therapy. There's nucleoside and nucleotide reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase strand transfer inhibitors, or just integrase inhibitors, CCR5 antagonists, and entry inhibitors. And I know you guys have learned a lot of this from Dr. Curry already in our previous test. Okay, so in this slide you can see the mechanism of action of different antiretroviral drugs. You can block CCR5, the CCR5 antagonists, or you can also block GP41, so you block the entry of the virus into the cell. You can also block integration of the provirus DNA into the host genome, and you can also prevent protease cutting of the DNA or the virus polypeptides and prevent it from budding from the cell. You can also inhibit viral reverse transcriptase with nucleotide analogs, which end up in early termination of the elongating chain. And different drugs that we've already heard about are tenofovir, emtricitabine, abacavir, lamivudine, zidovudine. And for abacavir, you need to remember to test your patient for HLA-B5701 because they could have an anaphylactoid reaction to the drug. A lot of these nucleoside analogs come in co-formulations just to lessen the pill burden on your patients. They have a lot of adverse effects though, simply because they use cellular thymidine kinase and they can block DNA synthesis as well. And so some of the adverse effects that you might see are lactic acidosis, hepatitis, pancreatitis, peripheral neuropathy, and lipodystrophy. And there can be some resistance that I'll talk about later. For non-nucleotide reverse transcriptase inhibitors, they are not nucleoside or nucleotide analogs, but they do bind near the catalytic site, so they prevent reverse transcriptase from doing its job. There's 3 of them to be noted: efavirenz, nevirapine, and delaverdine. And these can there's a lot of resistance to these actually because the virus only needs to require a single mutation, so you just need to be aware of that. There's also protease inhibitors, which prevent the proteolytic cleavage of viral polypeptides. If you remember the DNA genome, there's GAG and POL, and they need to be cleaved in order for a virus to be viable outside of the cell. Some major protease inhibitors are atazanavir, darunavir, and ritonavir. And Dr. Curry mentioned ritonavir boosting, which is basically, since it is a potent inhibitor of cytochrome P450, you can give a little bit of ritonavir, not really a therapeutic level, but just enough to inhibit cytochrome P450 and then sort of boost up the therapeutic levels of the other protease inhibitors, mainly because there's a lot of adverse effects associated with protease inhibitors, including diarrhea, hyperglycemia, and lipodystrophy, mainly diarrhea. There's also integrase inhibitors, which prevent integration of the proviral DNA into host genome, and the most notable is raltegravir. So we also have some more novel drugs such as the CCR5 antagonist and entry inhibitors. The CCR5 is a co-receptor located on macrophages and CD4 positive T cells. So if you antagonize those, then you prevent the binding of the viral GP120. But you need to make sure that you test for the virus tropism to make sure that it doesn't bind instead to CXCR4 or a mixture. Otherwise, it won't be effective for your patient. And this is Maraviroc. Another one is enfuvirtide, which is structurally similar to GP41, so it also inhibits entry into the cell. And these are kind of novel drugs that should be really reserved to those who might have resistant HIV after coming off of their other medications. So what is highly active antiretroviral therapy? It's a combination. They say that there's a backbone and a base. So for the backbone, you select two nucleoside analogs, and then for the base, you select one of either the non-nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors, or entry inhibitors. And you have to use a combination of 3. If you use 4, it's not any more effective, and you can't use 3 of the same kind. Otherwise, you could develop resistance. So when do we provide antiretroviral therapy? Well, we don't just give it to anyone who's HIV positive unless there are some other indications for it. So we absolutely give it if their CD4 count is below 200 or they have AIDS-defining illness, or if their CD4 count is between 200 and 350. We definitely recommend initiating it, and definitely to pregnant women because we don't want vertical transfer of HIV. The problem with the antiretroviral therapy is that once you start it, you have to continue it for the rest of your life. So you have to make sure that your patients will stay on it. If they have a higher CD4 cell count, treat them if they are motivated to be treated, or if they are part of a discordant couple relationship where one partner does not have HIV, or if they have other comorbidities such as viral hepatitis, coronary artery disease, etc. So now really, what do we give to our patient in real life? If the person has never taken antiretroviral therapy before, these are some of the options that you can give them. And a theme of all of these 4 is tenofovir and emtricitabine combination nucleoside analogs for initial therapy. And if your patient has already taken some drugs before for HIV, it's a little bit trickier. You have to find out what they've used just to see if there's any resistance to that. So you test the virus for resistance. There's some like in vitro, phenotypic, and also genotypic testing. And then you try to identify 3 active agents that you can use against their virus. Sometimes it's not possible. And if you only have one choice, you should just go for it. But otherwise, 3 is best. So let's talk a little bit about resistance. The best way to avoid drug resistance is to maintain viral suppression. If your virus is replicating out of control, then there's more chance for a resistant mutation to pop up. So the mutation rate of HIV is 2 to the 10 to the minus 5 per nucleotide polymerase per replication cycle. So what does that actually mean? They have about 1 mutation in every 1 or 2 nascent proviruses. So sometimes a single mutation can lead to resistance to nucleoside analogs, but sometimes it takes multiple mutations for certain analogs such as zivofudine and stavudine. A single mutation can actually wipe out all the non-nucleoside reverse transcriptase inhibitors, so that's pretty scary. But good thing is that most protease inhibitors have a high genetic barrier to resistance, so it takes a lot more mutations for them. Okay, let's do a little bit of acid-base overview. All right, so metabolic acidosis. That is when you have a low pH, obviously, acidosis, but also low bicarb. And that's because whatever acid is accumulating in your body, maybe it's a keto acid or lactic acid, it's chewing through your bicarb, so you have lower bicarb levels. Metabolic alkalosis, you would have a high pH because it's alkalosis, greater than 7.4, and also high bicarb. Respiratory acidosis, low pH, again, acidosis. And high PCO2 because you are not blowing off the carbon dioxide, so you have higher partial pressure in your blood gas. If you are respiratory alkalotic, you have a high pH and low PCO2 because you're hyperventilating and blowing off all the CO2. So in general, your PCO2 and bicarb should go in the same direction. Either they both go up or they both go down. When one goes up and one goes down, that means you possibly have a mixed acidosis and alkalosis, possibly with respiratory and metabolic acid-base imbalances. So that's where things get a little bit tricky, or a lot bit tricky. There's a lot of calculations that go into that, and I don't think we have a lot of time to discuss it. We just wanted to go, briefly through it. So I'm not going to discuss it. So now that you know all about acid-base physiology, let's go to our patient. Okay, so looking at his blood gas values, his pH is 7.43, which is still pretty normal, but I guess you could say it's higher than 7.4, so slightly alkalotic maybe. His CO2 levels are borderline low, 35, and his bicarb is 17, so that's low as well, just borderline. So CO2 and bicarb going in the same direction, so I'm assuming that it's not a mixed acidosis, alkalosis of any sort. And it's probably respiratory alkalosis since his respiration rate was 22, he's probably blowing off the CO2, and that's why he's alkalotic. And to explain the or the pressure of oxygen, that's also low because of his pneumonia or his infection that's leading to pulmonary shunting and hypoxia. Okay, so hopefully you guys are still awake. If you guys have any questions, don't hesitate to call me on my cell phone. All right, bye.